Frank Delacroix spent 31 years as a construction foreman in Macon, Georgia. Big hands, bigger laugh. The kind of man who showed up to his grandson's baseball games 2 hours early just to help set up the bleachers. 4 years ago, Dr. Julian Wells put him on metoprolol for blood pressure that had been creeping up since his 60th birthday. Frank didn't argue. He took the pill every morning with his coffee, the same way he'd taken his lunch break at noon for 3 decades. Routine, trust, no questions asked. But something shifted, not overnight, slowly, like a tide going out so gradually you don't notice the shoreline has moved until your boat is sitting in mud. By this past spring, Frank had stopped taking his boat out on Saturday mornings. His wife Carol noticed first. He used to be up at 5 a.m., thermos packed, tackle box loaded. Now he was still in bed at 8, telling her his legs felt like they were full of wet sand. He skipped his grandson's game in April, skipped it again in May, told Carol he'd catch the next one. There was no next one for 3 months. One Sunday afternoon, Frank stood up too fast from the porch swing to grab the mail. The world tilted. He caught the railing, but barely. Carol checked his pulse with the little monitor her sister had given her for Christmas 2 years back. 49 beats per minute. Resting. Frank is 74. Nobody had told him that was even a number to worry about. Here's what nobody wants to say out loud in a rushed 15-minute appointment. It probably wasn't age pulling Frank off his boat. It probably wasn't age keeping him off the bleachers. What Dr. Julian Wells would later uncover pointed to a medication that may have quietly outgrown what Frank's 74-year-old body could still safely handle, and nobody had gone back to check. Frank was on one of the 2 most commonly prescribed blood pressure medications given to people over 60. And the question almost nobody thinks to ask before swallowing that pill every morning is this. Between amlodipine and metoprolol, could the one sitting in your cabinet right now be quietly working against the active life you worked your whole career to finally enjoy? The answer isn't the same for every person listening to this. And it depends on something most doctors simply don't have time to walk you through during a standard visit. Before we get into the 2 drugs themselves, you need to understand one thing. Your body at 70 handles medication in a completely different way than it did at 50. Not a little different, fundamentally different. After 60, your artery walls lose elasticity. They stiffen, the way a garden hose left out in the cold winter gets rigid and cracks easier than a fresh one. That stiffness is why your systolic number, the top one, becomes stubborn. It's the number tied most closely to stroke risk, and it's the number that makes medication choice so critical in this decade of your life. Your liver slows its processing speed. A dose that cleared your system efficiently at 55 can sit around longer at 73, building up in your bloodstream like unopened mail piling on a counter. Your kidneys filter slower too. Your nervous system reacts less quickly when your blood pressure drops suddenly. That's the actual mechanical reason standing up too fast can send someone in their 70s to the floor while a 30-year-old barely feels it. None of this means a medication is automatically dangerous. It means the same pill behaves differently in the body it enters. This is what I call a mismatched prescription. Not a bad drug, not a careless doctor, just a treatment that was matched to who you were years ago and never updated to match who you are now. And your body in this decade is simply not the body it was originally prescribed for. Let's start with amlodipine, because understanding what it's actually doing inside you changes how you think about every side effect that follows. Amlodipine is a calcium channel blocker. Picture the muscle cells lining your arteries like tiny gates. Calcium rushes through those gates and tells the muscle to squeeze tight. That squeeze is a big part of what creates pressure. Amlodipine blocks a portion of that calcium traffic. Fewer gates open, less squeezing, the artery relaxes and widens, and blood moves through with less resistance. For someone past 60, this matters in a specific way. Remember the stiff, cracked hose problem we just talked about? Amlodipine goes directly at that stiffness. It's one of the most effective options for bringing down that stubborn systolic number and reducing stroke risk, particularly in people with underlying artery disease. The dosing approach here matters more than people realize. In a younger adult, a doctor might start at a full standard dose right away. For someone over 65, Dr. Julian Wells and most physicians following current guidelines will typically begin with a noticeably lower starting dose than what's given to a younger patient, increased gradually. often over several weeks, only if the body tolerates each step comfortably, and only under direct medical supervision. That's not doctors being overly careful for no reason. That's respecting a liver that clears the drug slower and blood vessels that react harder to sudden pressure changes. If this is helping you connect some dots, type the word clarity in the comments below. It tells me you're following along, and it helps this reach someone else who needs to hear it. Now let's turn to metoprolol, because this drug takes a completely different road to the same destination, and that difference is exactly what determines whether it belongs in your morning routine or not. Metoprolol is a beta blocker. Where amlodipine works on your blood vessels, metoprolol goes straight for the heart. Your heart has receptors that respond to adrenaline. Every time you climb stairs, get startled, or even just stand up, those receptors get a signal to speed things up and pump harder. Metoprolol blocks that signal. The heart slows. Each beat becomes gentler. Less force pushing through the pipes means lower pressure. For someone who's had a heart attack, who's living with heart failure, or managing an irregular rhythm, this isn't optional. It's protective. Metoprolol reduces how hard an already strained heart has to work. In those specific cases, it isn't just a blood pressure pill. It's doing a completely different job. But the dosing margin for seniors is tight. Doctors typically start with a dose that's significantly lower than what a younger patient would receive, increasing slowly, with heart rate checked at every step. And here's the one rule I need you to actually write down. You never stop metoprolol cold. Not for a headache. Not because you feel better. Stopping abruptly can trigger a dangerous rebound, a sudden spike in heart rate and pressure that can land you in an emergency room. Any change has to be gradual, and it has to happen with Dr. Julian Wells guiding it, not on your own timeline. Now I want to introduce you to Roz Alvarez, 69, a retired hairstylist from Tucson, because her story shows exactly why this comparison isn't as simple as one drug bad, one drug good. Roz had been on amlodipine for 2 years. She loved her Tuesday and Thursday morning mall walks with her sister. 3 laps before the stores even opened, coffee after. Around month 14, her ankles started swelling, not a little. By evening, her favorite sandals wouldn't buckle. She switched shoes twice. Then she switched to slip-ons entirely. Then, one Thursday in June, she just didn't show up for the walk. Told her sister her feet felt like bricks. What Roz didn't know, what most patients on amlodipine never get told, is that this swelling isn't fluid retention from the kidneys. It's the drug relaxing the arteries more than it relaxes the veins, so fluid pools downward under gravity right into the ankles and feet. It's uncomfortable. For someone with balance concerns, it can turn into a real fall risk, not just a cosmetic annoyance. Here's the twist in Roz's case. She also had a mild irregular heartbeat that had gone undertreated for years. When Dr. Julian Wells reviewed her full picture, not just her blood pressure numbers but her heart rhythm too, metoprolol actually became the more appropriate choice for her, despite the fatigue risk. Her heart needed the protection amlodipine was never designed to give. Her case was a mismatched prescription in the opposite direction. The safer-sounding drug was actually the wrong fit for her specific heart. That's the part almost nobody explains clearly. Amlodipine's biggest complaint is swelling in the lower legs, along with occasional flushing, mild dizziness on standing, or palpitations. Metoprolol's biggest complaint is a heavy, dragging fatigue. Patients describe it as losing their drive, their get up and go, sometimes with a heart rate that dips low enough to cause lightheadedness. And in seniors with COPD or asthma, it can tighten the airways even at a moderate dose. Neither one is universally the villain here. The mismatch between the wrong drug and your specific condition is what quietly erodes an active life after 60, not the pill by itself. The pill in the wrong body, at the wrong dose, without anyone checking back in. Now here's the part that concerns me more than almost anything else we've covered today, and it rarely gets airtime. The danger of either medication doesn't live in isolation. It lives in the context of everything else in your medicine cabinet. The average adult past 65 is taking 4 or more prescriptions daily. Many take 7, 8, sometimes 10. Each one looked safe on its own when it was prescribed. Nobody sat down and looked at the whole shelf at once. Amlodipine gets broken down by an enzyme in your liver called CYP3A4. That same enzyme processes dozens of other common drugs, certain antibiotics, antifungal medications, even something as ordinary as grapefruit juice can slow that enzyme down. When it slows, amlodipine builds up higher than intended, more swelling, more dizziness, a higher chance of a fall nobody saw coming. Metoprolol carries its own quiet risk here. Combine it with digoxin, or stack it next to another blood pressure medication, and heart rate can drop into territory that isn't just tiring, it's dangerous. Fainting becomes a real possibility. The safety margin shrinks fast, and usually nobody notices until something happens. These aren't rare, unusual cases you'll never encounter. They're happening right now, in ordinary kitchens, to ordinary people whose full medication list has never once been reviewed together as a complete picture. So what do the actual guidelines say? The American College of Cardiology and the American Heart Association agree on one core principle: blood pressure targets in seniors have to be individualized. For a generally healthy older adult, getting systolic pressure under 130 is often the goal. For someone more frail, managing several conditions at once, pushing that number too aggressively, can do more harm than the high pressure itself. In these guidelines, amlodipine sits near the front of the line for straightforward high blood pressure in seniors. No complicated heart history involved. Metoprolol sits in a different position entirely. It's not typically the first pick for plain hypertension. It's reserved for situations where the heart itself needs direct protection, after a heart attack, with diagnosed heart failure, or an arrhythmia that needs controlling. In those specific cases, it isn't a backup option, it's essential. If that distinction is landing for you, type the word individualized in the comments, and make sure you're subscribed, because the next part is where this gets personal for you. So let's answer it directly. Is one of these pills ruining your active life after 60? Here's the honest answer, and it isn't the dramatic one you might have expected. Neither drug is inherently the villain. The pill ruining someone's mornings isn't always the wrong molecule. It's often the right molecule at the wrong dose, prescribed for the wrong reason, without anyone checking back in 6 months later to ask how you're actually doing. That's the mismatched prescription in its purest form. Amlodipine becomes the problem when swelling goes unmonitored and mobility quietly declines. Metoprolol becomes the problem when it's prescribed for plain blood pressure control in someone whose heart never needed that level of protection in the first place, and the fatigue is written off as just getting older. Knowing this isn't enough on its own. You need to walk into your next appointment with Dr. Julian Wells ready to ask specific questions. Not vague ones, specific ones. Write these down. Save them on your phone if you have to. 1. Based on my complete health picture, is this medication still the most appropriate first-line choice for someone my age? 2. What specific symptoms should I be watching for in the next 4 weeks, and at what point do I call your office instead of waiting for my next visit? 3. Has my full medication list, every pill, every supplement, actually been reviewed together for interactions, not just each one on its own? 4. What is my individual target blood pressure, and has that number been adjusted for my age and overall condition, rather than a generic chart? 5. How often should we sit down and reassess whether this is still the right medication or whether the dose needs adjusting? Any physician worth your trust will welcome these questions. Dr. Julian Wells won't see you as difficult for asking. He'll see you as a patient who's paying attention to your own body, which, frankly, is the only person who's with you every single day of the week. There's one more thing worth mentioning here. Something small you can start noticing on your own between now and your next appointment. Not a treatment, just observation. If ankle swelling from a calcium channel blocker is something you're dealing with, some seniors find that a simple habit, standing up every hour and doing 30 slow heel raises, lifting up onto your toes and back down, helps the calf muscles push pooled fluid back upward. It costs nothing. It takes 2 minutes. It's worth mentioning to Dr. Julian Wells at your next visit, not as a replacement for anything, just as something to track alongside your other symptoms. Now let's go back to Frank, sitting on that porch swing in Macon, catching himself on the railing with a resting heart rate of 49. Carol insisted on a full medication review. Dr. Julian Wells looked at everything: Frank's heart function, his complete history, every bottle in that cabinet, and confirmed something important. Frank had never had a heart attack. no heart failure, no arrhythmia. Metoprolol had been treating his blood pressure alone, doing a job that didn't require that level of cardiac slowing in the first place. It was, in every sense, a mismatched prescription that had simply never been revisited. The transition to amlodipine happened carefully, starting low, monitored over several weeks, exactly the way it should. By early August, Frank's resting heart rate had climbed back into a normal range. Carol said it was like watching someone wake up after a long, heavy sleep. The boat came out of the driveway again on a Saturday morning in late August, thermos and all. He made his grandson's next 3 games in a row. He did develop a little ankle puffiness by evening, the kind Roz had dealt with. But this time, it was caught early, mentioned at the next appointment, and managed before it turned into a reason to stop moving. Frank's story isn't a miracle. It's what happens when a medication gets matched to the actual person taking it, not just the number on a chart from 3 years ago. Most people who go through a proper reassessment like this notice a shift in their morning energy within a few weeks, sometimes before their next blood pressure reading even changes. That's usually the first sign the mismatch is being corrected. And if you found this useful, the next thing worth understanding is what happens when 2 or 3 of these medications get stacked together in the same cabinet. Because that combination is quietly behind more falls in people over 70 than either drug alone, and almost nobody's full list ever gets checked for it. Your blood pressure prescription isn't something to leave running on autopilot for the next decade. It deserves a real conversation, updated as your body updates itself, with Dr. Julian Wells looking at who you are right now, not who you were the year the prescription was first written. This video is for educational purposes only and does not replace personalized medical advice from your own physician. Never start, stop, or adjust any medication without consulting your doctor first. If this helped you see your own morning routine a little differently, subscribe, turn on notifications, and tell me in the comments, are you on amlodipine, metoprolol, or both?